Hey, everybody, welcome to this session today, which we're calling Love at First Byte. And we're hoping will be an interesting collection of stories and experiences that some great panelists have been brought together to help all of us understand better what the value is that we're getting out of our investments into data infrastructure and projects and all of this work and time that we spend trying to create data environments. What are they actually good for? We're hoping to share with you some of those experiences. I'd like to quickly introduce our panelists, and they'll each get a chance to go into a little bit more detail in a moment. First of all, we have with us John Henderson, who's CIO of Children's Hospital of Orange County. We have Ian Brooks, Interim Director of Health Data Compass at the Colorado Center for Personalized Medicine. We have Sandra Elliott, Vice President of Life Sciences and Innovation at Hackensack Meridian Health. I'm Michael Ames, Senior Director for Healthcare and Life Sciences at SADA. SADA is a HealthIMPACT sponsor. We are a Google Cloud consultancy, and my work is all about bringing Google Cloud solutions into the healthcare industry. When we began working with HealthIMPACT on this potential session, I got thinking about how do we create something that will actually help people to maybe feel like all of this work that we've been doing is worth it. Sometimes we spend so much time focusing on the problem, putting solutions in place that we hope will yield value, that we don't ever take the time to actually look back and say, where were the wins? Or what were the lessons learned? Or what were the important things that we got out of this? And that's what I've asked these panelists to think about and to prepare and to share with you. Myself, I'm going to inject a few more lighthearted vignettes in the middle around work that a team that I was responsible for here in Colorado back some years, was responsible for some years back. And so I'm just going to start with one. This is going to be one of three, and we're saving the best for last. So the first one, we're in Colorado, and a few years ago, it was still controversial that Colorado had legalized marijuana. And it was, of course, a big discussion in the healthcare industry. We had a handful of doctors from our hospitals come to us. So my organization was responsible for this analytics infrastructure. They came to us and they said, we think we're seeing an increase in facial fractures coming into the ED ever since marijuana was legalized. And do you have any data that would help us to understand that? And we were fascinated by this. We're like, what could possibly be behind this? Setting aside the data for a minute and just thinking about the causes and effects, we could not figure out how this might happen, because if anything, take a little marijuana, you should be sitting down and feeling pretty relaxed. But are people walking into walls? Are they hugging the wrong guy and getting punched in the face? Like, we had no idea. We took the data and we analyzed it, and we actually did initially see what looked like a significant bump in the presentation of facial fractures in the ED, like within 2 weeks following the legalization of marijuana. We dug deeper and found early on that, in fact, there was what we first looked at that was confirming our hypothesis was actually just because the hospital system had bought a new facility, and we were now assuming their numbers, and that had occurred right around the time of legalization. It looked like there was a bump up, but we're taken as a ratio of the whole. If anything, what we found was a small decrease. And then we found some more interesting things, like the fact that men are likely to come in with facial fractures at a rate of 5 to 1 over women. So, well done, men. We feel like we successfully debunked the hypothesis that marijuana makes you more likely to break your face. It might make you less likely to break your face. But what is likely to break your face is being a man. So be careful out there. With that, I want to turn our time over to John Henderson. John, if you don't mind, will you tell us a little bit more about your role? Tell us a little bit about what makes your organization unique, and then we would love to hear your Love at First Byte story.
Sure, thank you. I'm John Henderson, the Vice President CIO for Children's Health of Orange County. I've been here about 4 years. I'll say what makes CHOC unique is really its fanatical emphasis on quality and outcomes improvement, a tremendous passion for that. I think one of the things that CHOC has been, I'll say, a leader from a pediatric health system perspective is in population health. We've been on this journey for a number of years, even before I joined. And the approach has not really just been about our existing patient population. The whole scope of the program was really designed to take care of children in the entire Orange County region, whether they are a patient of ours or not. So looking at population health from a really macro lens and not just our direct patient population. So really excited about the work that that team has done.
That's really cool.
You know, I'll say my love at first, my first love at first Byte story, it's going to date me a little bit. But prior to joining CHOC, I was working at a pediatric health system in Houston, Texas, and got a call from our performance excellence leader and said, hey, we need to be able to generate data in real time to understand how many patients are coming into our ED. And we need this in real time. We have a huge patient flow problem, and the only way we're going to be able to solve it is with this information. Now, keep in mind, we did not have an analytics program at the time. So pulled my team together and said, okay, we'll figure out something, but what are we going to be able to do? So we're an Epic shop at that institution. And so my team came together and we said, okay, we whiteboarded how we were going to do this. We came back and were able to deliver a real time at that point was every 15 minutes to really track the flow of patients into our ED. The lean performance excellence team was able to leverage that information to really change the trajectory of our patient flow and backlog into our ED. And that was really the first time where I realized, wow, we can make a significant impact from a clinical operations perspective by really harnessing and leveraging this wealth of information that's sitting in our database, and not just to use it for transactional reporting. So really big impact on me, and really kind of set us on the path of me thinking about how do you create a program to really harness the power of data.
John, I love that. And I got to say, one of the things that stands out to me that you went over very quickly, and this is so often the case, is somebody from the clinical side of the business coming and asking a question that sounds probably to them pretty easy. We need real-time data on flow in and out of this department, right? As though there's an easy button for that you're just going to push and make that happen. How did you sort of bridge that gap between this isn't something we've done before, have infrastructure for, ready things for, and we're going to deliver this and it's going to actually make a difference?
Wow, I would have thought you were in the room. That's exactly how it came up. So, you know, my approach, one of the things I love about what I do is I love solving problems. So when I first heard it, the first thing that came across my mind was, how in the heck are we going to pull this off? Now, that's my inside voice. What I said to him was, we're going to figure it out. I said, I can't tell you how just yet, but we're going to figure it out. And had no idea how this is going to happen. Because like I said, at the time, we didn't have an analytics program. We had some really smart developers. We had some great report writers, some really great database engineers, but it was really a scenario of, well, I know this is an important initiative. It's being talked about at all levels of the organization. Our CEO is talking about it. So I knew it was something we were going to have to do. And so it really went from talking through more about, okay, in addition to this, is there anything else you're going to need other than this census information? And so we went from that to really talking through, okay, yeah, we need the census information, but we also want to understand where they go. Where are patients going once they leave the ED? Are they being admitted, or are they being asked for follow-up? And so that led us into not only just delivering the census, but understanding the kind of full scope of where they were really trying to get to. So once we had that conversation, then you pull the really smart people into the room and say, okay, here's the problem. We are going to do this. What I really need from you guys is, how are we going to do it? And think about this from the context of everything's possible. And so team really just got to work and said, they came back in probably 3 days and said, here's how we're going to do it. And then they just went to work and made it happen. I was able to go back to the director of performance excellence and say, okay, we have a plan. We know how we're going to do it. And his first question was, is that going to be ready at the end of the week? And of course, I smiled and said, not at the end of the week. I said, I will let you know by tomorrow by when. I said, but I guarantee you it won't be 3 months from now. It is going to be a short cycle. And we were actually able to get this up and running in about 2.5 weeks.
I love that, John. And I love the flow from here's the impossible request to here we're going to be heads down, figure out the nuts and bolts technical solution. And then the other end of that, here's the actual impact that it had, right? You had an impact there that has a positive effect on clinical outcomes, makes that whole dreaming of the impossible and doing the impossible very, very worth it. I'm sure there was a lot of stress and late nights making it happen. Great story. Thank you. One more quick segue from me. This one's going to be short and disappointing to you. We analyzed the numbers every which way possible. We're here in Colorado, lots of unpredictable weather. We get a lot of snowfall, and there is a common belief out there that we will see a baby boom 9 months after a major snowfall in Colorado. I am sorry to tell you, there is no data whatsoever that supports that hypothesis. So apparently the snow falls, you spend your day shoveling, everybody goes to bed grumpy, and it has no impact on the population charts, at least in the state of Colorado. Speaking of Colorado, our next panelist to speak is going to be Ian. Ian, will you tell our audience here just a little bit more about yourself? What makes your organization unique? And then tell us your Love at First Byte story.
Yeah, sure. So I'm Ian Brooks. I'm the director of Health Data Compass at the Colorado Center for Personalized Medicine, close ties to Michael. And I think what makes us unique, we have two major things that make us stand out. One, we are completely embedded in Google Cloud. So we're one of the first ones, actually under Michael's leadership. And a great thing to inherit is the fully GCP embedded clinical data warehouse, along with all of the analytic tools in the Google ecosystem. And then something else that really stands out to folks when we talk is the structure of our system. So we don't belong necessarily to the University of Colorado, right? We belong to four major stakeholders, which is UC Health, healthcare system, CU Anschutz, where we're all based, Children's Hospital Colorado, and CU Med, which is our physicians group. So having that diverse group of stakeholders really shifts our remit, and I think it opens worlds of possibility that we might not have if we were purely linked and embedded in an academic medical center.
Outstanding. Yeah, tell us your story.
So I think it's another time traveling story, which is apropos given the Doctor Who poster behind you, Michael. Of early in my career, so I'm a geneticist by training, but I moved into health informatics 2007, 2008, working in translational genomics and all of this, and gradually fell further and further into the data side of things. And it was one of my first big projects that I got to be the project manager, ended up program manager of. And it was changing high-risk asthma in Memphis through partnership. So CHAMP was the acronym, and it was CMS funded. And a significant collaboration. So we all worked on the grant together, which was a great learning experience. And it was one of those copies that you sort of go back to pick from over time, because there was some really smart text in there. But it really brought together the Children's Hospital that we were working with at the University of Tennessee. And in the Children's Hospital, we had pulmonology, allergy, the emergency room docs, social services, my group that I was working in, which was biomedical informatics. And again, it was one of these things where we're saying, how can we reduce to zero pediatric deaths from asthma, right? It should not be happening at all. And at the same time, let's do more than that. Let's get out and make sure that we are shifting perceptions in the community where it was seen as an acute condition. And Memphis has some of the worst air quality in the United States. And that's partly because there's a lot of industry in the city, and it's partly because the Mississippi River's right there. There's floodplains to the west, and a lot of dust just blows across the city. So incredibly high rates of pediatric asthma. It's obviously a chronic condition. It can be a lifetime condition, but through medication management and preventive care, you can really lead nowadays a healthy life. So there was a huge educational component to it. So we started the build, data dictionaries, this, that, and the other. And I got to admit, I was completely out of my depth when we started on this, which I think is why it really resonates still with me after all this time. And we're pulling EHR data, so we know where our patients are. We've got obviously emergency room data, so we know what's going on, when kids are coming in, when families are coming in, when ambulances are going in and out. We've got finally managed to get hold of medication data and start to track when our inhalers being refilled, and more importantly, not refilled, right? That fed into the social services data, where we've got outreach then to families saying, we know the archetypal little Timmy you haven't filled his inhaler, it's expired, right? So if he has an asthma attack now, and meanwhile, you've got nurses doing outreach at the same time to try and make sure that families are aware of what's going on with the kid and preventative care. The bigger this got, the more effort that went into it with the analytics and things like this, the more we saw the buy-in, not just from the hospital, which actually then funded a 24-hour or 24/7 nurse hotline for families to call in the middle of the night, but it actually led into the city donating data to us. So we started to get legal data for evictions and landlord problems, for bed bug mitigation, for cleanup, for trying to help elevate these families, although they may live in poverty. There are better ways to live: vacuum cleaners, HEPA filters, things like this. So it was just really astounding that once that snowball started rolling, what we were able to pull off. And the thing that really got me, that one big one, was for us being somewhat remote, not being clinicians and all of that, was the social services folks getting in touch with us, telling us they'd had their first patient council meeting and they'd heard from parents that this program had saved lives, that they knew their child was alive because this program had educated parents on what to do, on making sure they had these phone banks. And the one that really, almost literally reduced me to tears was hearing that there were kids who were saying they'd learned from the nurses talking to their parents what to do when the adults had these chronic asthma attacks, and that you had little kids now either calling 911 or calling the hotline. That was a really profound moment for me, and that was really the addiction to the career.
Yeah, Ian, that's an incredible story. That's fantastic. Lots of interesting little insights along the way that I think we could pick up. One that I think is worth looking into is how to get to those outcomes. It wasn't just a data problem. You brought together a number of different groups, clinical, social, data, and otherwise. And I worry a little bit about how oftentimes maybe we hamstring ourselves by focusing problems on as only data problems, and we don't realize the incredible teams that are sometimes required to make change. What would you attribute to in that situation? Was there some really great visionary leader? Was there a really good steering committee? Or to what would you attribute the success of all those groups coming together to make this successful?
It was a good combination of visionary leadership from the division chiefs and department chairs who were doing it. It was a very gender balanced group. The men were the numeric minority in the group, which I think, can lead to some changes in tone and cadence in meetings, which allowed people to speak up a bit more. And actually, one of the things they really did is the hospital leadership encouraged the pulmonology, allergy residents and fellows to take part in this as part of their training program. So there was a lot of younger folks in there as well who were really driving it through. And then on our side in biomedical informatics, as part of a CTSA, there was a big drive that I push for still for team science, right? It's now, we'd say it's 2021. Back then, it's 2012. You can't do this alone, right? There's more to it. You need, at least on any problem, you have to have a statistician in the room, but then executive buy-in for that big picture, that 1,000-foot view with it coming down from the executive to really help those of us on the ground in the trenches, whatever the analogy is, to keep your eyes on the prize, the big picture.
Outstanding. Thank you. Great story. I would love to hear more about it. But let's move on. So here's my last vignette, and this one does have a payoff, I promise, before we get to our last panelist. So the other interesting Colorado fact that we were curious about is this legend that Denver Broncos fans are so passionate that they will injure themselves during a game, but not go to the emergency room until the game is over. And the great thing about that is we have data about ED admissions and what would be expected and normal variances there and times of day. And then we have data on when football games are being played. And we looked at things like pre-game segment and during the game and post-game. And we were able to build a statistic model that told us, based on normal behavior, how many folks should we see showing up to the emergency room on a given Sunday night or Monday night, depending on the game. And were there any changes in those patterns based on where we were in the game itself? And the answer turns out to be yes, that we can show with data that Coloradans will wait until after the game is over before they take their emergency room issue to the emergency room, but only during the Super Bowl and only if the Broncos are playing. Under those conditions, they will risk life, health, and safety rather than miss the game. So that much plays out. And moving now to our last panelist, Sandra, again, thank you for being here. Will you please tell us a little bit more about you and your organization, what makes it unique, and then tell us your Love at First Byte story.
Absolutely. So as you mentioned earlier, I'm the Vice President for Life Sciences and Innovation at Hackathon Meridian Health, which is one of the actually is the largest health delivery system in the state of New Jersey. So we cover about half of the state. I think one of the things that makes us extremely unique, besides being, kind of Manning fans, if you will, from using the football analogy, is that as a health delivery system, we don't just have hospitals, we have one of the largest footprints of a multitude of different types of touch points with patients, if you will. So virtually almost from, definitely from cradle to grave, basically, but we literally have every element of the continuum you could ever imagine. Connecting all of those is still an ongoing journey, but it definitely makes us unique. I think tied with that, which kind of fits into my realm of interest, is that we are driving ourselves to transform how healthcare is delivered in the future. And obviously that ties a lot to data. And I think that, over time, we will learn so much by paying attention to what the analytics are telling us. But I want to tell you my first Love at First Byte story, which is kind of interesting from the standpoint of thinking about the N of one, going from big data, if you will, to small data. I like to say small data is sexy, just as sexy as big data. Many years ago, we had a program where we were trying to really reduce readmissions for congestive heart failure patients, just like every other organization in the country. And we decided with the data that there were certain areas of discharges that we really wanted to focus our impact on. So not those patients that were going to nursing homes initially, not those patients who were getting support by home care when they were discharged, but those patients who were going back into the community without needs, if you will, and needs being the term of, kind of next level of care, but were kind of on their own as soon as they walked through the door. So we used some of the technology that we had in place to really collect data, the typical kind of how's your heart rate, respirations, coughs, and of course, changes in weight. And we were able to, using some data analytics tools, really help kind of cue in our key care management staff when patients were starting to trend in the wrong direction with weight. So we would place calls to those individuals. And as a result, you get a lot of interaction with that N of one, if you will. And what we actually found out is by one small gentleman who said, I kind of know why my weight is always off on Tuesdays. And he said, I have a feeling that I know a few other people that, have been in your hospital that probably have the same issue. And the care manager at the time said, well, why would you say that? He said, honey, the best chicken is the rotisserie chicken at Costco on Saturday, because they just keep running those things through that machine because everybody's getting fresh rotisserie chicken. And of course it's pumped full of sodium. And it's really by Tuesday that weight goes up. And it was interesting because then that care manager started interviewing different individuals in a key location. And absolutely, there were a certain group of patients who were always seeing each other on Saturdays getting their rotisserie chicken. So we were able to help them understand how they could minimize the impact, not me personally, but the care manager. They could still have their chicken. They could go get it on Saturdays, but here's how you can minimize the sodium impact on that. And also, actually had some conversations with some of the key physicians in the area, so they were able to give them some ideas of how they could manage their medication just a little differently, and it made a huge impact in those individuals. And I think it's really mission critical for us all to begin to understand that no matter what, data or change, it's all about individuals. It's about the people that we're trying to take care of. And I think even if you impact one, you've made an impact. And I think all data is critical, but translating that data into how we can change something for the better is what I think we're all about. So, but that was my love at first Byte story, literally, literally.
I just made the connection. Sandra, that is wonderful. And thank you very much for that. I really love that idea that small data is just as sexy as big data. And I think that is illustrated in the stories that we've shared today, because at the end of the day, all of them came down to, here's a change that was made that is ultimately affecting somebody's life, somebody's health, right? And this is a tough business and industry to work in. There are hard days and there are long nights, even when there isn't a pandemic on, right? And people ask, well, tell me why it is that you work in this industry? And it's because of that. It's because we hope that the things that we do are going to save the life of somebody's child, son, grandmother, whatever that condition may be. And recognizing those sort of small outcomes from our big efforts in data, I think is key towards sustaining the energy that we need to keep pushing the innovation and making things happen. So this is a great time, I think, to sort of pause our panelist discussion here. My thanks to Ian, John, and Sandra for joining us today. We have time now to open this up and to take some audience questions.
Hello.
Hi,
So,
everybody.
folks, yeah, you might have noticed I got a haircut in the last 30 seconds. What can we say? The magic of modern technology. But thanks to all of you who've attended our conference session. You might have noticed some conversation happening in the chat. If you'll go in there, chat in questions or into the Q&A box, we're happy to answer those. Thank you, Megan. I appreciate the shout out for my haircut. Yeah, so we've got about 15 minutes. We can use as much or as little of that as we need for questions. Maybe while you are thinking of those and entering them into the chat, I had just a couple more follow-ups for our panelists here. One, Ian, you made this really interesting statement about gender balance in the project that you were working with. I would be interested to hear a little bit more about that. How is it that you found that having gender balance in the organization managing this data project actually seemed to have a positive income on the impact on the outcome of the project?
There's a couple of things. First, the caveat that obviously, I don't know if any of members of study section who reviewed my grants are sitting out in the audience right now, so I'm going to cage a little what I'm going to say. But I think that, it's incredibly well documented, and it's also the lived experience of more than 50% of the population, but the dynamics in conversation in daily life are completely different between men and women. You can ascribe that to whatever you want, hormones, culture, whatever it might be. So what I've often found is when you've got large groups of men, it gets competitive. Right? It gets really competitive, whereas working in groups of women, you tend to get a much more collaborative environment where all voices are heard. I think all of us as male managers and directors, it's incumbent on us to try and address these things, learn about them, and, lean in on trying to make changes. So, there was that. And then a large group that was driving the grant were on the social services side of the Children's Hospital, which was primarily women. So having their voices at the table and their experiences, because they're they're seeing these families in real time in their home environments and things like that. It brought a lot of power to what we were trying to do. And I think it made it real and stopped it disappearing up the ivory tower into its own fundament.
I think that's great. And I think that a lot of us can attest to that. One of the things that has been interesting from my perspective, as someone who grew up in the tech industry, which remains heavily male dominated, but has been working in the medical field, particularly with emphasis on biomedical research, is I have found in my experience that we're actually much more accustomed to gender balanced organizations in the research field, certainly than we are in the high tech field. And as I kind of move in and out of those circles and the different aspects of my job, some of those cultural differences that you're describing, I think, become highly apparent. So thank you for that. John, actually also then on the topic of culture, there was a chat conversation about differences in data collection and analysis between adult care and pediatric care. We talked a little bit about, differences in instrumentations in the ICU and those kinds of things. But also, I think an observation that you and I shared together is that the culture within pediatric care organizations is different from adult care organizations in many cases. Would love to hear your thoughts on that and what it means for people who are trying to solve data problems in healthcare, in pediatric care. What's a common pitfall that somebody coming in blindly, maybe from adult care, is going to trip over trying to bring solutions to the pediatric care industry?
Right. Thanks, Mark. Good question. One of the key things from a culture in, say, a blind spot is, analytics or vendors are come into the organization and they bring these examples of what they've done in adult care. I was in a meeting not long ago and there was an example of doing mammography. And just right off the bat, when you're in pediatrics, you're looking for the little things. Do they recognize that we are pediatrics and we don't do adult things here? We deal with very tiny people, tiny kids, and they're varying in range and they grow over time. And so those types of things are really important. And it gives you a sense of whether or not the vendor has done their homework and they recognize their audience. I think the other thing about it is when you're in pediatrics, everyone is really trying to provide the best care, whether you're adult or peds. But from a pediatric perspective, it really tugs on your heartstrings because they're kids and you're in this facility and you're trying to provide this care and you're being very, very specific and deliberate about what's important. And so that cultural difference between what's important in a NICU versus an acute floor in an adult facility, or even in an ICU in an adult facility, a tremendous amount of difference in what goes into that. The number of handoffs in a NICU and the number of physicians and clinicians that have to consult to create that care team. You may have 10 to 12 physicians and support services teams working on one NICU patient, as opposed to in another scenario, you may have a primary intensivist and maybe a specialist consult, but you have to think about what are all those different data elements that's really necessary to drive the quality and improvement in a NICU setting. And you can translate that even into some of the other service lines in pediatrics. So you really have to get to a much lower level of granularity than you might in an adult facility.
I think those are some great examples. One comment you said that resonated with me just now was around the intense concern for the kids. And here's an observation that I'll make, not trying to throw adult care under the bus, but we spend a lot of time on the technology side talking about how do we make systems HIPAA compliant, how do we make them secure, protect the data. And when we are talking to adult organizations, the concern is very much around the conversation we'll have as its sort of fulcrum, the need to be compliant with regulation. When we're having that very same conversation in a pediatric care setting, the fulcrum is the need to protect the kids.
Yeah.
Right.
We see that it covers, right? I mean, because we have the adult hospital and the children's hospital I'm talking to executives on one side versus executives on the other side. And everybody's in it always for the best, right? I don't want to diss on anybody, but it is really different. And then especially when you talk to IT, making sure that is understood from the adult IT groups to the pediatric side. And then as the service provider, how are we meeting those standards across both organizations?
And I think in addition to that, there's the connection, obviously, to making sure, particularly on the technology and analytics side, that they're focused in on solving a problem. So in NICUs or ICUs, one of the problems that everybody has is trying to maintain or minimize the risk of infection and sepsis. So understanding even how, while it is about the kid in NICU, and yes, it is about the adult in the adult ICU, you can begin to build the regulatory and compliance environment once you begin to understand and target the core problem that you're trying to solve, because that's scalable, right? That goes across any organization, whether you're in pediatrics or you're an adult or even in long-term care. It's a good problem to focus on because everybody's got it. So analytics, the nuances and maybe the algorithms behind the analytics may be different for those patient populations, but they're still trying to solve the same problem.
Sandra, I'm really glad that you jumped in there. And I'd like you to talk a little bit more too. We had a great question here from Shahid, one of our moderators, just to talk a little bit more about your particular title, VP of Life Sciences and Innovation. That, and for the benefit of the audience, when we were prepping for this, Sandra was saying, I've got a little bit less of a data angle, a pure data angle, and some other things. And you should go look at her LinkedIn profile, product development, innovation, investment, some really fascinating kinds of things. Talk to us more about what's going on at Hackensack, that they decided that they needed this position. Not every hospital system has a VP of Life Sciences and Innovation. What was important about that? Why did Hackensack go that direction?
I mentioned in the intro, one of the things we truly are trying to do is solve the problem of how do we do a better job or transform how we can deliver care for the future that's really about changing the outcome. So we know we have consistent problems throughout the organization when it comes to challenges that every hospital or health system face, whether it's infections or readmission rates or different levels of outcomes. If we're trying to change a clinical outcome and knowing that clinical outcomes can drive financial outcomes, tying those two together and understanding that one of the ways in which this organization wants to address innovation and innovating to transform is bridging the gap between science, what's going on today, the science of biology in the future, and pharmacogenomics, the whole 9 yards of everything that's going outside of the traditional health system, to how do we translate that into making the lives of the patients that we serve better. And bridging those from an innovation perspective is why we have both of these two roles kind of merged into one, because we know new diagnostics. I mean, we have two core businesses: diagnostics and therapeutics, right? Diagnosing a problem and trying to solve that problem. Those are our two core businesses, and tying those two together means that you have to be able to get life science companies, biotech companies partnered with us in order to really figure out what are the greatest ways to solve this problem and understand what works and what doesn't work. Otherwise, we're all kind of, focused. It's a shotgun approach. Yeah. We're just all hoping for the best based on a solution versus let's go and tackle this problem.
So I often get asked, what is it? How do we know if this hospital or hospital system is going to be the kind of, have the sort of innovation mindset that might make them want to have conversations with us and technology about, new platforms and things that can help to develop that technology? Is it big ones? Is it small ones? Is it East Coast? Is it West Coast? And my answer is there's really no demographic that predicts if an organization is going to push the boundaries around innovation. It's a cultural matter within that organization, and lots of respect to Hackensack for being one of those kinds of organizations trying to do things new and different and exciting. Same thing happening at CU, same thing happening at Chuck, which is why you guys are here for this conversation. I want to repeat here a question we got in the chat from John Warner, just directly. How much is any speaker using their data insights to directly nudge patients to better health outcomes or better, faster recovery or wellness? Ian answered in the chat. John, any thoughts you want to share? How do we close the loop? We've collected data. Now, how do we turn that back around to help improve health outcomes?
Right. So, one of the things that we're looking at doing, particularly in the PEDS focus, I mentioned earlier on, we're heavily focused on population health. And so one of the elements that we are really focused on is the whole wellness aspect, and how do you provide additional resources? And whether that's mental health resources, whether that's better eating, where to find the right type of foods. Because even within Orange County, a very affluent county, there are still a number of areas and counties within cities within Orange County where there are food deserts. And so what we're looking at doing from a care management in our population health module is to be able to provide that assistance. We're doing it today through our care managers, but we are on the verge of building that out so we can actually push information out directly to via whether it's text message, using our portal, so that we can provide that information based upon the patient profile. So something we're very interested in. We're actively working on it. And so I think that's really the future. We want to be able to meet folks where they are. And so there's a variety of channels that we have to provide this information and insights to. And mobile is definitely one of them, because a number of our patient population, that's what they interact with, that mobile smartphone device.
John, thank you. Folks, I think we need to wrap it up here so that we don't push people over time. Sandra, Ian, John, thank you so much for your time, your preparation, your great stories, the answers to the questions here, everyone participating in the conference. Thank you for your attention. Happy to reach out for follow-ups and things afterwards. I'm just throwing my email address into the chat there. It's supersimplema@sada.com. You can find me there. I might be able to connect you in with these folks if you can't find them through the other conference information for future follow-ups and collaboration. We'll wrap. Thanks, everyone, and have a great rest of your day and a great rest of the conference.
Bye-bye.
Thanks, everyone.
Thank you.